Good. Thank you all. I was watching the clock here a little bit. Let's try to be efficient and limit our conversation to 15 minutes. Anybody want to start? Alta, and then Jeff, and then Keith.
Aaron, for you, you made a comment about the bad outcomes from heteroplasmy in the cytoplasm injection efforts in the late 1990s. I'm assuming you're talking about Jacques Cohen's work, but I wasn't aware of the data that showed the bad outcomes. Can you just expand on that a little bit?
So this is, this is definitely not my area of specific expertise, but in reading a few background articles on this topic, it was my understanding that some of those outcomes led to, that work led to increased risks of, non-viability of fetuses or potential outcomes in the children that emerged from that higher than they might have expected, which was one of the reasons that the effort ultimately was stopped. But I would definitely defer to somebody who was actually the researcher on the field in terms of what specifically the statistics were and how much difference there was and that kind of stuff.
So Alan,
that's why I asked him the question, why did you stop doing it? It was the two-Turner syndrome that he presented that got
the exos,
that were reported that caused him to stop. I mean, he didn't say that, but that's why he stopped doing that.
Thank you.
There was also a case of pervasive developmental disorder.
Right. That was hard to tell.
Hard to tell. Right.
Thank you.
Jeff Botkin.
Yeah, question for Skip. So, in the context of that, sort of asking you about how you framed part of the problem here, and our tolerance for risk depends on what the alternatives are that we've framed. And so if you look at it purely from the child's perspective, we might tolerate a fairly high level of risk for the child based on the intervention in order to prevent what would be a devastating disease. On the other hand, if we frame the problem of how do we help women who have mitochondrial diseases have healthy children, then we might have a lower tolerance for risk for the child in order to achieve that outcome, because that's an outcome that can be achieved without the intervention. Does that question make sense? So how are you framing that in terms of how much risk you would be willing to tolerate for the future child?
Well, that partly explains why I initially framed it the way I did, which is the prevention of mitochondrial disease and the selecting of diseases where you would imagine there'd be a high penetrance and a high risk if that mother was given the only option to have a genetically related child of natural reproduction. And not knowing the science well enough, I don't know how I've taken that 750 and I might have carved it down to 25 for all I know. But as you develop the technology, then that would be a place to start. How fast you then move to less severe diseases and the like, and to other diseases that are of older onset, I think would be an open question. And at least when I listen to all the issues around safety, it sounds to me that most of the issues that need to be resolved around safety are as much just around the technique, the technology, and some of the non-clinical stuff that people were suggesting. It's not clear to me, at least for mitochondrial disease, we need a whole lot of more work around proof of benefit, because it appears to me that you could establish that from just the percent heteroplasmy that you get as a result of the procedure. Now, long-term outcome issues, I think, are a bit more complex. Yeah, I mean, I guess I would just, a bit more complex to think out how much, but, we don't, to carry trials out to that extent would be, I think, very difficult, and that's why long-term follow-up is important. But also, the natural issues of child outcome, I think, would also be at play there. Some of the comments made about what happens in the natural lottery of being a child anyway.
Keith. And then I've got Jim, and then I'm going to put myself on the list, too.
So I was struck by the contrast between Aaron's presentation and John's, because you have such fundamentally different starting points for your analysis. So Aaron you started with this, you see this as an issue that's akin to the way the FDA handles drug or device or different interventions. And you use a model that says how the FDA evaluates new innovative products, especially where there's uncertainty, applies here, and we should use that in weighing these kinds of questions. And John, you started from the standpoint of procreative liberty as a fundamental good, freedom from interference, and then leading to the question, what's the FDA even doing in this realm? Or at least that's the implication that I got. Now, it's clear that the committee's charge is to advise the FDA. But it's such a different perspective, the two perspectives. And so I guess this led me, I just wanted a kind of a conversation about this question, about what the framework we should apply here is. But the other question for John really is, how in your view do you deal with the risks then? If, in other words, if you were to apply this kind of fundamental value of procreative liberty and of freedom from interference, which is what you were saying, how in that model do you grapple with the risks associated with the procedure, whatever the risks might be? How does that come into play? Because this isn't just there's an intervention here that has to be grappled with.
Well, I started with the general concept of procreative liberty to see if this was an exercise of it. And if it is, which I think it is, then the question is, under what circumstances could it be restricted or banned? And it's at that point that one would have to show a strong, compelling reason for doing so, for interfering. It seems to me that the FDA model comes in at that point. It's not that it's irrelevant at all. It's just I had a different starting point of the concept of procreative liberty as such. It's a presumptive right that can always be overridden with sufficient reason, and the FDA concerns strike me as sufficient reasons that the risks to the offspring or to the woman undergoing it should count heavily if they indeed exist. However, longer-term concerns, more airy concerns, such as slippery slope or interfering with nature, where will this lead, seem to be not specific enough. They're too moralistic and too unconnected to individuals here. So that's how I would deal with that. It's not the risk is irrelevant. It just comes in at a different place in the analysis.
So I guess from my point of view, I'm a little bit worried about interjecting this sort of constitutional liberty talk into this area, because I think that it does frame the discussion differently and leads to interjection, I think, of rights that are not really appropriate in this circumstance, where at least it's clear to me that this sort of technology falls under the statutory authority of the FDA to regulate products. And I guess I'm sure people in here know about the regenerative sciences case where this was litigated at the circuit court level as well about the FDA's authority to regulate modified human products. And so I just think that you have to be. I think that interjecting those kinds of considerations as a starting point does exactly what you're saying, Keith, sort of frame the whole conversation differently, and I think leads us to a place that is a little bit more troublesome from my point of view.
And I'm not suggesting you start out your report with an analysis of procreative liberty and then do everything under that. The only point is that it's an important conceptual way of viewing things going on here. There is an important reproductive interest at play in a woman who wants to have her own genetically related children, and then what means of doing that become acceptable, and there we can get into regulatory structures.
If I can just add, I see a connection between your question and Jeff's question, and the connection I see is is if we frame it as helping women have healthy children, then it is more in the reproductive liberty side. And in my desire, at least initially, to frame it as it's not just about having healthy children, it's about the prevention of disease, is precisely to bring into bear the regulatory framework that talks about the risk-benefit of that analysis.
I think it's illustrated by our regulatory system. So ART is very lightly regulated, if at all, and so if you approach it as ART, then we think about it as right to reproduce and constitutional rights. Research, human research, is pretty heavily regulated. If you approach it from that direction, then, oh, this is just another example, and we just put it into that framework. And, you know, nobody has a right to say, you must do this research for me so I can live, or whatever, you know. So it's a byproduct. It shows in our country how we look at these two different things, and here's a kind of a clash of it.
So let me now interject. This is a question from Jim Childress. We've heard a lot today about the importance of follow-up for MRT and also about the ethical and practical difficulties of doing this in the United States. Do any of you, so this is to everybody, see any effective and ethically acceptable ways to overcome these difficulties in the U.S.? And Aaron, you gave us a little bit of a start to that, but others of you, and Aaron, of course, too, please, any thoughts about the follow-up issue and its challenges?
Well, I guess I would link it to the comment, I guess, that John Turnbull had said about trying to locate this into centers that have the expertise. It's not been my impression that if you root these kinds of programs into large, well-established centers that have the longevity, that follow-up, I mean, granted, individuals will drop out, they'll move, et cetera, but if you take a commitment to do that follow-up right from the beginning, I don't think it'll be that as hard as we think it will be.
Yeah.
I'm thinking of fetal treatment programs. You know, boy, I mean, the nurses study seems to find people for 30, 35 years and continue that as well. So,
I mean, so I guess I agree that I think there's plenty of historical examples where we have been able to do this kind of follow-up. You know, certainly if you look at large, long clinical trials, there's a substantial amount of money invested in ensuring that a person is involved with the trial for multiple years. There's examples like the clozapine example where, you know, people who are on clozapine had to do CBC every, 6 months or a year. And so, in order to stay on the drug, then you have to agree to that in order to be involved in this. And so I think that there are plenty of examples, successful examples that can be employed in the past, successful models to try to ensure that as much patient follow-up, active patient follow-up happens. And then, as I kind of just threw out there as another idea, automatically placing, as a quid pro quo for getting involved in this research, automatically placing these, these children into an ongoing health insurance program so that we could also follow up their claims data and interactions with the healthcare system without worrying about switching from one health insurer to another might be another supplementary way of getting additional data to do long-term follow-up.
I think that's an interesting idea. I was trying to think of other incentives to keep people plugged in. If you set it up originally as this is a collaboration, you're not just a subject, you're part of you're participants, you are in this with us, and a joint kind of project where people might buy in more psychologically and cooperate in that way.
Great. Alta? And I'm going to close.
I'm going to go back to the comment that Keith made that generated this exchange between you all, because I first of all, it was the committee that asked specifically for some attention to procreative liberty, so there was a reason why that was being brought in. But, Aaron, I'm not sure I understood your answer, because if the government were to adopt a policy in law that somehow prohibited the movement toward mitochondrial replacement therapy based not on safety issues, not on public health concerns, but on moralistic grounds. It does strike me at that point that you'd have to ask whether or not that could be done against a backdrop of either ordinary rights or fundamental rights, however they're understood, right? Now, we're not even close to that point, because we haven't gotten anywhere close to the issue of the resolution of all safety issues for both the pregnant woman, her child, and future generations. And we may never get to this. But wouldn't you agree that if safety is used as a subterfuge for actually what are more those inchoate moralistic concerns, or if there was an overt legislative effort on moralistic concerns, that at that point we would indeed have to ask whether or not the government has to meet a higher burden of justification before they'd be allowed to stand in the way of somebody who wants to access a technology for their own reproductive purpose?
Yes.
It's like, the law professor is coming out of you here. Asked and answered, counselor. So I want to actually have a bit of a follow-on, but to a more structural point. To Skip's, I thought, really interesting analysis about subpart D versus subpart B, and whether you don't think both really apply. It's a little bit unusual, right? We don't generally confront this question, right? So it's not one or the other. It feels like it's sort of both. And what do we do in a case like that? So yeah, please.
Well, B as you know, is a fairly sparse. It's really got nothing in there except in terms of how one balances risks and benefits. It talks about what you do if there's no benefit to the woman, no benefit to the fetus, benefit to the woman, benefit to the fetus. But and it's mainly driven by. I won't go there anyway. It's it doesn't have that risk-benefit analysis, and it's linked to who consents, and it's linked to then who makes decisions about viability. And so there's other political issues that are driving that. So yes, it applies, but frankly, what's happening here is to the benefit of the fetus. I mean, and I think it just sort of stops there. If you're treating disease, I mean, it's not to the benefit of the fetus if you're doing age-related infertility, unless you want to argue being genetically related to your mother is a benefit to the child. And there may be some data on that, but it's certainly a lot weaker than data on not having a mitochondrial disease. So, so yes, it does apply, but my point is that it's just bare. It's a bare cupboard. You open it up, and there's nothing in it that provides advice about how you balance risk and benefit. And that I think subpart D provides a sort of richer history and framework to do that under.
We could talk a lot about this, I think, but we won't, at least not at this moment. So thank you all for very, very much, both for your thoughtful comments and for hanging in there with us past the time we told you we would be done.